Right, here we go. Hello, everyone, and thank you for watching this webinar on personal injury, billing, coding, and documentation. There's no audio taping or videotaping allowed, and any unauthorized reproduction, dispensing, forwarding, or copying of this presentation is illegal. The information in this presentation is for educational purposes. It's not intended to be legal advice. We don't provide legal services. I've made every attempt to make certain the information in this presentation is 100% accurate. However, it is not guaranteed. Let me tell you a little bit about myself before we get started. My name is Dr. Marty Kotler. I'm a chiropractor. I'm also a certified professional compliance officer, certified billing and coding specialist. And let's see, I consider myself kind of unique because most chiropractors are not certified coders and most certified coders are not chiropractors. So you'll see throughout this presentation how I take my clinical experience and I add it to my coding expertise to help you show you, to help and show you how to maximize reimbursement, how to make sure you're billing and coding properly, how to make sure you're not leaving any money on the table, making sure you're compliant. That's what we do. We also do billing. Target coding now does billing. Um, so you'll see I'm not a clinical expert, but you will see I will share some of my clinical expertise. When it comes to coding, that's a whole different story. All right. Also, I've written books and training manuals on chiropractic billing, coding, documentation, also for acupuncturists. Medicare, it now covers acupuncture. So I'm going to be very busy with my acupuncture clients, creating compliance plans for them and billing and coding seminars. Also for physical therapists, we do trainings. I write articles to the major publications you see coming across your desk, like Chiropractic Economics and Dynamic Chiropractic, the American Chiropractor. I also write articles for many state association newsletters, and I'm a speaker at many state association conventions nationwide. By the way, those of you listening to this that you're part of your state association that's looking for a guest speaker, our calendar is pretty full for the rest of this year, but let us know if you are looking for a speaker for your state association. I can usually get a sponsor, and we put on a really good show. All right, so back to the presentation. Personal injury, record keeping, billing, coding, documentation. Let's get going here. So many patients choose chiropractic care for the treatment of injuries relating to auto accidents, on-the-job injuries, other types of trauma. Now, when you see personal injury, most of you probably think auto accident. It doesn't have to be an auto accident. Yes, it is most of the time, but you could have a patient say, "Hey, I was on vacation in a hotel and I slipped on a wet floor by the pool. Person fell, hurt their back, come in to see you." That's personal injury. It's more bodily injury more necessarily than auto accident. And these types of injuries that people experience and present to your office with there's a wide variety. Of course, soft tissue injuries and pain and stiffness and swelling, but some of these conditions can become complex, like visual disturbances, sleep disorders, dizziness, numbness, traumatic brain injury. Now, who can provide these services? Of course, you, the doctor. We break them down here into two categories: QHPs, qualified healthcare professionals, like chiropractors, medical doctors, physical therapists, massage therapists, acupuncturists. These are individuals that have been trained, they're licensed, and can bill insurance companies and get paid directly by insurance companies. Clinical staff also can do therapies, however, they're not able to bill insurance directly. So clinical staff, excellent individuals, been trained, maybe they have certifications in some things, but would not be able to bill insurance directly and get paid, like a nurse or a rehab tech, an exercise physiologist, a Pilates instructor, an aide. And the supervision levels are different. There's three types of supervision levels: personal supervision, direct supervision, general supervision. So in the chiropractic setting, direct supervision is fine, which means the doctor is somewhere in the office and you have staff. If your state allows staff members to provide the service, that's called direct supervision. Personal supervision isn't typically required. General supervision doesn't really apply to chiropractic practices. Medicare requires the PT to be on site when the PTA performs the service. Again, that's an example of direct supervision, and these rules can be complex. Sometimes they're hard to find. In some states, CAs, they're not allowed to do anything. In some states, CAs cannot even put a hot pack on a patient. So make sure you check with your board on who can on what type of services you can have staff members perform, who you can delegate services to. I was talking to one of my clients. Here's a classic example. I said, Doc, I see that you're doing ultrasound on patients. She says, yes. I said, do you personally do the ultrasound? She said, no, I have my CA doing it. I said, well, in your state, CAs are not allowed to do ultrasound. She said, what are you talking about? My CA is a nurse. You see, this is where some doctors get confused. She thinks because my CA is a nurse, she's qualified, she can do those things under me. No, it's up to your scope of practice. You could have a CA that is a medical doctor. Doesn't mean the medical doctor could do medical procedures under your supervision. If you're supervising a person, it doesn't matter what their training is, within your scope of practice, that's what counts. So if you're in a state where CAs are not allowed to do anything, it doesn't matter if your CA is a orthopedic surgeon, cannot do anything under your supervision. So then we have, patients coming in, they have to fill out the proper intake forms for personal injury. Make sure you have all the, you know, um, right forms for personal injury. For example, your regular health history form should be different for a pre-PI case. I recommend you get personal injury forms. Make sure all your PI patients sign your HIPAA forms, your notice of privacy practices. Here's our example. It's a nice form to have things like this. Could we confirm your appointments by email, text, or phone? Could we leave a message on your answering machine? Could we discuss your condition with any family members? We have an open room, so get all the forms out of the way, and now you have a PI patient come in to see the doctor. These are the 6 things we recommend: history, exam, diagnosis, set goals, list of services, and the schedule of care. So when you treat a PI patient, you're going to need to do a history. So if you're billing, for example, 99203, you have to meet these requirements. You have to have at least 1 chief complaint in your notes, 4 HPIs, which is, you should know what that is. HPI, history of present illness. The pain is, it's throbbing, it's worse in the morning. Patient stated that ice makes it feel better. All those HPIs, throbbing, dull, burning, achy, those are HPIs. 4 of those. Review 2 to 9 systems, and you have to review 1 item from the past family of social history. So that's 99203. A lot of docs bill 99204 for their PI patients. Just make sure you're meeting the guidelines. Now, you may not be meeting the guidelines in your notes, but the insurance company is paying you anyway. That's common. I see that a lot. Dr. Bill's 99203, he doesn't have 2 to 9 systems. He doesn't have here with the exam, 99203 requires 12 findings. I see this often where the doctor submits notes, right? With PI, I'm assuming you're submitting your notes with your bills. So you submit your notes for your exam, your 99203, and you don't have 12 findings, but you still get paid. You got lucky. You're getting lucky. Make sure you have 12 findings. And this is just a quick summary here of your 99203. Requires a detailed history, which means 1 chief complaint, 4 HPIs, 2 to 9 systems, 1 PFSH, need to be documented, 12 exam findings. Make sure you know what constitutes an exam finding. For example, if Mrs. Jones comes in and she has neck pain and you say, turn your head to the right and turn your head to the left, and it's painful in both directions, does that count as 2 findings according to the guidelines, the E&M guidelines? That's where I'm getting this information from. That's what the insurance companies use, the E&M guidelines. Does not count as 2 findings. So make sure you know what constitutes a finding. This webinar is a quick one. It's hard for me to get into too many details, but if you go to my website or go to the Target Coding YouTube channel, you'll see more information on how to constitute or justify the 12 findings. And then we're going to have diagnosis codes for your PI patients. You have pain and symptom codes. Sometimes they say, hey, use neck pain as a diagnosis, and doctors go, what? Neck pain? That's not a diagnosis, that's a symptom. Well, you could use signs and symptoms if you want. If you don't have anything better, use signs and symptoms. That's what the ICD-10 guideline state. See, I master all the guidelines. There's the 1997 E&M guidelines. There are the OSHA guidelines. There's the HIPAA guidelines. There's the ICD-10 guidelines, the AMA guidelines, the Medicare guidelines. These are all documents that I read all the time and I've mastered. So the ICD-10 guidelines state that, hey, if you don't have a definitive diagnosis, you could use signs and symptoms like neck pain and shoulder pain and knee pain. Muscle spasm. Okay, yeah. PI patient's definitely going to come in with muscle spasm. Here are your muscle spasm codes. Sprains and strains, very common in auto accidents, sprains and strains, and then you have episodes of care. So the episode of care or the encounter, the letter A means initial encounter. It's the last letter in the S codes. Now these S codes, you see these S codes? Like cervical sprain, S13.4. Any code that begins with the letter S means trauma, means injury. So these could be used. These are seems to be a natural fit for auto accident cases or any type of on-the-job injury, sprains and strains, right? S codes, again, trauma, injury, like what? Sprains, strains, fractures, contusions, traumatic brain injury, concussion. All of those codes begin with the letter S, and then you need an encounter. The last digit needs to be an A, a D, or an S. A means the patient is receiving active treatment, and you're the first provider the patient visits. D means subsequent encounter after the patient has seen another provider. And sequela means there's a late effect of an original problem. So if the patient has sprained ligaments and then develops, let's say, radiculopathy, now we have a sequela, a late effect. And if you have any questions on these, please submit them. I'm going pretty quick because I'm trying to cover as much information as possible in this short free webinar. So here are strains. Strains relate to muscles, sprains relate to ligaments. So you're going to use sprains longer than strains. Doesn't make sense to bill for strains for, after 30 visits, right? That looks weird. And we recommend, grading your sprains and grading your strains. Next, we have, hey, subluxation codes. Would you like to use subluxation codes? You're adjusting subluxation, so yeah. If you're doing an adjustment, my strong recommendation is to have subluxation diagnosis codes, either the regular M99s or the traumatic subluxation codes when it comes to PI. Non-PI, I don't think you need to use these trauma codes. Radiculopathy is a good one. Patient comes in, says, hey, doc, ever since the car accident, I have pain in my neck and pain radiating down my arm. So you may want to use M5412, but make sure you can justify it. I'm all into justification. Remember, I'm a compliance officer. I'm Mr. Goody Two-Shoes. My job is to protect you. Some of you may be older than me, but my job is to protect you like you're my children. Put a coat of armor around you, right? Those of you that have children, what's your number one goal in life is to make sure your children are safe and happy. That's what I do with my clients. I make sure they're safe and they're happy. How am I going to make sure you're safe and happy if you're going to diagnose a patient with cervical radiculopathy? I'm going to make sure you have these things in your notes that you have written down. Patient is complaining of pain, and the pain or numbness or tingling or weakness is radiating down. We did Jackson compression, a little Valsalva. We checked reflexes. There was some myotomal weakness. There was limited range of motion, subluxation. Boom, there you go. That's how you diagnose cervical radiculopathy without any diagnostic testing. And we have sciatica. Be careful, don't use unspecified codes. Get specific. It's either right or left. Disc disorders, disc displacements. Yeah, here we go. These are your herniated discs, bulge discs, sequestered discs, protruding discs. Disc disorder with the radiculopathy means there's nerve root compression. You need an MRI for this. Disc displacement without myelopathy, yeah, you could have a herniated disc without compression or myelopathy. Do you know what myelopathy is? Hopefully you do. Don't ever diagnose a patient with myelopathy if you don't even know what it is. We see that once in a while. And sprains and strains. Here's another thing I always get a kick out of. There's two sacroiliac joints, right? So how come we don't have laterality with the sacroiliac joints? There should be a right and a left. Well, we don't. Again, back to justifying your codes. Sacroiliac sprain. What should your note say? Yes, there was pain in the joint. Maybe it increases with lying down. You see, here's my clinical experience. I'm not the clinical geek. I'm just sharing some clinical recommendations. But now I am the code geek. I am the code expert. So if you do these clinical things, you'll be able to justify the right ICD-10 code. Little, it's like a little bit of a breadcrumb trail. Headaches? Yeah, patients can come in and say, hey, ever since that car accident, I've been getting migraine headaches with or without aura. Hopefully you know the definitions. In my practice, G43.009, that was the most common one. Without aura, not intractable, means the patient is responding to conventional methods, status migrainosis. His patient needs to be hospitalized. Acute and chronic post-traumatic headaches. What's the difference? What's the threshold? How do you know if a patient comes in and says, hey, Dr. Kotler, ever since the car accident, I've been getting headaches. How long ago was the car accident, Mr. Jones? If he says 3 weeks, you're going to use acute. What happens if he says 6 weeks or 8 weeks or 2 months or 4 months? What's the threshold to get him to chronic? Anyone know? The answer is 3 months. And then we have TBI, very common, traumatic brain injury. This is based on the time the patient loses consciousness. Also with concussions. Concussions, also time of consciousness. And then we have these. These are great diagnosis codes, but you can't just slap here. This one, ligament laxity. This isn't something you can just use lightly. You have to measure this. Sometimes you need to buy software. There's companies out there that could assist you with this. Can't just look at an x-ray and go, oh, ligament laxity. That's impossible to see just on a plain film. I don't know, I'm not an expert on diagnosing ligament laxity. Cervical kyphosis, this one's pretty straightforward, reverse curve. I love this one. Forward head carriage, whatever you want to call it, forward head carriage, forward head translation, abnormal posture, upper cross syndrome. You're going to see this with your non-PI patients. I think you're going to see this with probably 90% of the patients that walk into your office, especially the ones that sit at a computer or they look at their iPhone or their cell phones, their laptops, their iPads all day. This is what they look like. Sleep disorder, sure. Depression, anxiety, that could happen. Tinnitus, dizziness. And now your PI patients come in. What are you going to do? You're going to do adjustments, right? Chiropractic adjustments. Here are the regions, 5 spinal, 5 extremity regions. We're almost done, so type in your questions, please, if you have any. Then we have modalities. You're going to do modalities on your PI patients, I'm assuming. Supervised modalities, one or more areas, not time-based, not requiring one-on-one contact. The top 3, the most common, hot packs, traction, unattended stim. Let me know if you have any questions. These are pretty straightforward. You could put a patient on a traction, stim, and hot pack simultaneously. You leave the patient on those things for 3, 4, 5, 6 minutes, 10 minutes, bill one of each. Now things change with constant attendance modalities. Now things change because this is one or more areas each 15 minutes. The most common is ultrasound, 97035. And then you have vibration platforms. We get questions like that all the time. If you have questions on vibration platforms, let us know. The dry hydrotherapy activator. People ask us these questions. How do you build vibration platforms? So if you have questions on that, let us know. But ultrasound is the most commonly billed constant attendance modality. And now you could build this in units. So 1 unit, 15 minutes. You do ultrasound for 30 minutes. That's a long time, right? Well, if you do, that's 2 units. Now we have therapeutic procedures. Now things change because you have to apply clinical skills and you don't even need equipment, right? With a modality, you need a machine, right? With therapeutic procedures, it's based on your intended outcome. What are you trying to accomplish? So therapeutic exercises is for strength, endurance, range of motion, flexibility. Active procedure, neuromuscular re-education for improved balance, coordination, kinesthetic sense, also active procedure. Manual therapy is passive. You see the bottom row there? Patients just lying there getting worked on, that's passive. Don't bill 97110 for a passive therapy. Active therapy for 110, 112, and 530 means the patient is actually doing something. It's interesting. I just had a doctor. He spent $10,000 on a piece of equipment. It's some sort of fancy schmancy electrical stim device. I forgot exactly what the name was, but he spent like $10,000 on it. And the company's telling him to bill 97112. I said, no way. Are you going to be able to bill 97112 for a machine that's doing the work? 97112 means the patient is doing the work. The patient is doing the work. When you give somebody an adjustment, who's doing the work? You, the doctor. When you put a patient on a traction table, who's doing the work? The traction table. When you bill 97110, 112, or 530, the patient needs to do the work. You see the examples on your screen? Another thing I like to do is pair my codes. Just like you pair food and wine, you should pair your CPT codes and diagnosis codes. Let me explain. Your diagnosis codes, well, your CPT codes are what you're doing. Understand the what and the why. CPT codes are what you're doing, like an adjustment, x-rays, an exam. Your diagnosis codes are why you're doing them, sciatica, subluxation, pinched nerve, carpal tunnel syndrome. They should pair. I'll give you a couple of examples. You're doing mechanical traction, 97012 on a patient, pairs beautifully with cervical radiculopathy, M5412. Here's another really good one. You like to do myofascial release? Great. What happens if the patient has myofascial pain syndrome in the neck? Wow, that's a beautiful pairing. 97140 pairs perfectly with M7912. I consider myself a sommelier. You've heard of the term sommelier? It's a wine and food master. I'm a coding sommelier. I'll show you how to pair your codes. You're doing exercises, pairs beautifully with shoulder stiffness. You're doing an adjustment, pairs beautifully with subluxation. I'll give you an example of what doesn't pair properly. If a patient has knee pain and you diagnose the patient with M9906 and your CPT code is 98940, you see how that doesn't pair? That's ew. 98940, pair that with an extremity diagnosis? That doesn't make sense. 98940 is a spinal manipulation. It doesn't work with a knee subluxation. So make sure you're pairing your codes properly. And then in your SOAP notes, these are the most important. Well, these are one of the most important things for PI: duties under duress and loss of enjoyment of life. These items are typically broken down into categories including work, household, domestic, education. Knowing which type of duty under duress is important. When insurance companies evaluate the case, they need to know what the patient is having trouble accomplishing and track these. The reason why their back feels weak. Example, school. Every day since the accident on Tuesday nights, can't study properly or not be able to concentrate. Here, if a patient's in a car accident and they come in and say, man, I was injured badly, one of my first questions would be, Mr. Jones, are you still working? If the patient says, no, my injuries are so bad, I can't work, or yeah, I'm working, I'm doing my normal I'm doing my normal job. Big difference, right? Household, can you mow the lawn? Yeah. Take out the trash? Yeah. Wash your car? Yeah. Or no, I can't do any of those things, or I can do them partially if the patient is a student. Maybe they have trouble carrying their books from class to class. These are all key questions. You might even have a questionnaire that the patient just fills out. Instead of you asking all these questions, have them fill out a form. Domestic, patient says, you know what, I I'm in charge at home. I'm in charge of doing the laundry, washing the dishes, vacuuming, cleaning the house, preparing meals, taking care of the kids. I can't do any of that because of the car accident. Wow, that's important. You're a student? Yeah, I have difficulty concentrating. I can't carry my books from class to class. Now, back to the coding of time-based codes. One unit is 8 to 22 minutes. 2 units is 23 to 37. Be careful. If you do 2 codes at 23 minutes each, you think you could bill 4 units. No, you could only bill 3 units. Now, you ever have a patient come in and say, hey, my benefits are exhausted, now bill Medicare. Make sure you bill Medicare properly. In 10B, check yes. Yes, auto accident. If you bill Medicare as a secondary in a PI case and you put no to auto accident and Medicare pays you, you've submitted a false claim. You could have big problems. And in 11D, you check yes. And it says if yes, complete 9, 9A, and 9D. There you go. State Farm, so Medicare knows. Here's a sample PI claim. I like to, do diagnosis pointing, but if it doesn't affect your, your payment, you don't have to. You see 98941, I'm pointing to 3 regions. 97530, the therapeutic activities, is just pointing to A, B, and C. That's a thoracic lumbar region. And then I'm doing massage on the knee. So just an example claim there. All righty. Oh, so just a few closing comments. Just want to let you know, here's my contact information. If you need to contact me, if you have any questions about what we do, set up a free consultation if you have any questions on what we spoke about today or anything in general regarding billing, coding, documentation. Remember, now Target Coding now does billing, so you might want to use us for your billing service. Hey, listen, if you're happy with your billing service, fine. If you're doing your in-house billing and you're happy, fine. But if not, I have a client right now, has a great biller in-house, fantastic biller, wonderful, terrific. She's been with the doctor for like 12 years. But guess what? The office has gotten so busy. They're opening up another location. This one person is just overwhelmed. So they're going to be using our billing service just because of the heavy lifting that we're going to, help out with. And then we have other offices that they just have constant turnover. They hire a CA, billing CA, lasts 3 months and quits. Next one comes in, lasts 4 or 5 months and quits. So you have this constant turnover. Maybe you want to use us. Having problems with ASH? Need help with ASH? Do you want to get more visits out of ASH? Do you want to get more cash out of your ASH patients? The answer, if you are in network with ASH, I'm pretty sure you're saying yes to both. Schedule a live training, or you could buy our video. We recorded our last ASH seminar, so you could have a live one-on-one training for your office on ASH, or you can buy the video. And, we do webinars every week. We're doing a webinar later today on therapeutic procedures and modalities. We do them every week. We do webinars on different topics, usually 2 a week. So they're usually $99 each. If you become a member of Target Coding, $99 for the entire month, and you could log on to all the webinars, plus unlimited Q&A. So you may want to consider becoming a member. We have a boot camp. Oh boy, this has been super popular. We have a Target Coding CA boot camp. We've covered every single possible job description a CA could have, from front desk to patient relations to billing to insurance to collections to helping the doctor in the back with the therapies and doing the notes for the doctor and how to be a compliance manager for the entire practice. We covered every possible job description in these 4 modules. Each module is 2 classes, so it's a total of 8. The spring semester is starting in March. You may want to come on board. Here's our, we have client testimonials on we have something called our chiropractic compliance program. It consists of HIPAA, billing and coding, OIG, and OSHA. Only $199 a month, and we will get you compliant. You will be a 10th degree black belt in compliance. This way you don't have to think about it. Right now, if you do not have any billing and coding compliance manuals, by the way, billing and coding compliance manuals are for the staff, not for the patient. Every day now I'm getting articles on whistleblowers. You may have heard that term in the news lately, whistleblowers. These are staff members that are turning the doctors in, and they're getting a percentage. One staff member was a whistleblower for an office in Minnesota. The staff member just got a percentage of the collections. The office was fined over $1 million. The staff member, the whistleblower, got $270,000 as a piece of the settlement. So the federal government, state, local agencies encourage not doctors, but staff members or patients, come forward. Tell us if your doctor is billing fraudulently. So that's what this is about. This compliance manual is about getting your staff to understand how you bill and code. They're going to sign a form that they understand that you do everything right, and then that's it. You're covered. So that's part of it. Only $199 a month this way. Every time you read a journal, you're going to see something about compliance in it. Every seminar that you go to, you're going to see something about compliance in it. And you're going to say, oh man, I got to get to that one day. I got to do that one day. Just do it. Contact us. Let us do it and get it over with. We have tons of happy, happy clients that have gone through our compliance program. I'm not saying it's fun, but it's just something you got to do. When you go to the airport and you're going through security and they pull you out of the line, is that fun? No, but it's just part of the safety world we live in. All right, so I think that's about it. Let's see, anything else do I want to cover before we get to questions and answers? Oh, we have forms that we sell. I don't care what software you have. ChiroTouch, Genesis, ACOM, you still need forms. Letters of medical necessity, fight back letters, HIPAA forms, ABN forms. We got them all. We got them all. You want us to do a SOAP note checkup on you? We can do that too. Anything to do with billing and coding and documentation, you want to buy a book? This is the best book in the chiropractic industry as far as I'm concerned, as far as showing you how to bill and code. This is a guidebook. This isn't Chiro Code, which is a great book. This isn't the AMA CPT code book, which is a great book. Those are more references. My book is a guidebook. It tells you how to bill and what codes pay for the most visits. It's not just a reference. Oh, want to come on a cruise with us? We're doing a seminar on a cruise. You get 10 credits on a cruise. How much fun is that? Look at all these people having fun on our cruise. We can't wait for the next one. We just booked our third annual coming up in 2021, and videos. You need a video on anything to do with billing and coding? Staff member just comes on board. You can buy all our CA bootcamp videos now. You don't have to wait for the classes. They're available. You buy them now, then you could attend the live ones. And of course, we do seminars all over the country, billing and coding compliance manuals, Medicare compliance manuals, HIPAA compliance manuals. We got it all. So I want to thank everybody for attending. Let's go and take a look and see what questions have come in.